Thank you very much for joining us here today at our 4th out of 8 webinars in our Observatory webinar series on the COVID-19 response. Today we're going to talk about a very important subject, which is health financing and COVID-19, how to balance financial incentives for sustaining health services. As we all know and have seen and perhaps experienced, the COVID-19 crisis has put enormous pressure on financing mechanisms to ensure providers that they can treat COVID-19 patients and cases, but also maintaining other services, but also in many cases by keeping hospitals and other providers solvent when elective cases are cancelled. In this webinar, we will answer questions like what strategies have countries used to pay for COVID services? What have countries done to compensate professionals and providers for losses of income during COVID? How can financing mechanisms help sustain health service delivery, but also what lessons might we learn from other countries? And my name is Dietrich from the European Observatory in Health Systems and Policies. I will be your facilitator today. I will now introduce the program for the next hour. First, we will start with my colleague Erica Richardson. She will provide a short overview on our health systems response monitor, on which this series is actually based. She will tell us where to find it and how to use it. Then we will have a keynote from Wilm, Quentin and Ruth Waitzberg. They will provide an overview of strategies that we've seen used in Europe. And Wilm is a senior research fellow at the Department of Healthcare Management at the Berlin University of Technology, and he works in several observatory projects, and he is an expert in financing methods. Also, Ruth is a researcher at the Department of Healthcare Management at Berlin University of Technology, and she is also involved in the European Observatory in Health Systems and Policies and does several countries in our Health Systems Response Monitor. She is also a research scholar at the Myers JDC Brookdale Institute in Israel. And together they're actually in the process of writing an article on these responses in the various countries, and they will take us through some of their findings. Then we are going to move to 4 spotlight presentations from 3 different countries. We will first start with Mark Schreiner, who is the managing director of the Berlin Hospital Association, and he will provide the perspective of the hospitals and what the hospitals in Berlin, 60 hospitals in Berlin, have been doing during this pandemic and how they have dealt with some of the challenges. Then we will move to the payer perspective, and we're really glad that Wulf Dietrich Leber is here, who is the head of the hospital division at the National Association of Statutory Health Insurance Funds. And he will provide the perspective and talk perhaps a little bit about the negotiations and how the steps they've taken during the pandemic. Then we will move to Poland, and Marzena Tambor, who is an assistant professor at the Institute of Public Health at Jagiellonian University Medical College in Krakow, will take us through the Polish response, which was very different from the German response. Marzena is also a contributor to our HSRM website. Then the last country that we will go to is France. We have Marie-Camille Lenormand here. She works for the French Health Insurance, the CNAM, where she is responsible for international relations and benchmark studies within the Department of Strategic Research. And she will take us through the French response. In the meantime, Erica will monitor the chat box. So if you have any questions, please pose them there to us, and we will get back to them at the very end. So now I would like to give the floor to Erica, who takes us through the HSRM monitor. Erica?
Hello, everyone. The most important thing, well, one of the most important things to say about the Health Systems Response Monitor is that it's a collaboration, and it's a collaboration between the World Health Organization Regional Office for Europe, the European Commission, and the European Observatory on Health Systems and Policies. And what it is an online tool that lets you see how the health systems are responding to COVID-19 right the way across Europe and Central Asia. It organizes and shares information in 4 key areas. So firstly, it collects together the country information, it checks, organises and updates this to capture what country health systems are doing to tackle COVID-19. It also compares countries and sets them in context across a range of topics. And as the user, you're able to go into the platform, select the countries you're most interested in, select the aspects of the response you're most interested in, and draw those data together in one document. It also links to reliable and timely data, the international COVID-19 data, and provides all those links in one place. And fourthly, it analyzes the key themes across countries to give snapshots of what the different policy responses and setting these initiatives in context. And that's very much what this webinar series builds on. So the cross-country analysis pulls together the narrative threads of similarities and differences between countries. And this analysis is in response to questions which are posed by countries themselves, by WHO or the European Commission, but also it comes out of editors working on the HSRM platform, coming together and thinking about emerging issues and topics and picking up on patterns and trends that we're seeing as we pull the information together. We like to provide examples and good practices and link to key documents to inform policymaking area in this field. And these updates are provided as policies and practice evolve and as indeed the pandemic evolves. So there's the link to the analysis. The HSRM is accessible off our website, and Annalisa will share the link with you in the box so you can explore it at your leisure. But thank you very much for your time. Thank you.
Thank you very much, Erica. So now we will go to the keynote. I think Wilm will start. Wilm, the floor is yours.
Thank you very much for the opportunity to talk about health financing and COVID-19 and the work that we have done for the Health Systems Response Monitor. We have titled our presentation and the webinar, Balancing Financial Incentives for Sustaining Health Services. And this is because we had to find a quick title, but I think the topic of balancing financial incentives is really important because this was a challenge that many countries had to deal with. The financial consequences of for hospitals and physicians of COVID-19 have been twofold, and Ewout has already alluded to them. On the one hand, hospitals and payers somehow had to cover the extra costs related to the care for COVID-19 patients. And COVID-19 patients are high-risk patients, often high-cost patients because they require long treatments in hospitals. They require isolation treatment. Investments in new capacity were needed, and there had to be a reorganization of care pathways according to hygiene and physical distancing measures. At the same time, besides these direct financial effects of COVID-19 and the related costs, there are more indirect effects that are related not only to COVID-19 patients, but also to other patients, because many providers lost a lot of income related to the elective services that were put on hold, or just simply because there were fewer patients to be treated by the providers, which did not come to be seen by doctors or hospitals. And this also continued in many countries even after the end of the lockdown. And the second effect, in fact, in many countries was more important than, or was a greater challenge in many countries than covering the extra COVID-19 related costs. And when working on comparing all EU countries, the Health Systems Response Monitor, we tried to classify the mechanisms that have been used by different countries according to this framework, which you see on the right side of the screen. And the payment mechanisms that were used were either to compensate the income loss or to pay for COVID-19. And the different approaches that were used were either to use higher payments, to introduce new payments, to use an old payment mechanism, or to change the payment mix. And we have classified the different mechanisms that we have identified across countries in the Health Systems Response Monitor, and by working directly with colleagues from almost all EU countries to identify the different mechanisms in these categories. I will now start going the mechanisms that have been used to compensate income loss, but I will not necessarily follow this structure, but I will rather start with the most important mechanism. Now, to compensate income loss, in general, governments or public payers have aimed to bear the financial risks of COVID-19 by covering the loss of income. And in doing so, the payments had to balance the aim of fairly compensating income loss, so to not provide too much compensation, but also to provide enough compensation to compensate the income loss, and to provide incentives to restructure service provision. And the most important mechanism that has been used across countries is that they used some form of continuing the old payment. What old payment means is that the usual target budget or the usual target budget that had been set at the beginning of the year was simply continued in many countries, independent of the change in activity as a result of COVID-19. And this was the easiest measure. And many countries, because they have these target budgets that they use, they didn't really have to make any adjustments. But this leads to the question of whether there will be an adjustment at the end of the year, and this may lead to uncertainty. And Poland is a country where this is the case. Maybe my colleague Marzena will talk about this later during her spotlight. In other countries, they developed a compensation based on the previous year's turnover. So even if they didn't have this usual budget that they provided to hospitals, they developed a compensation mechanism based on the previous year turnover and continued paying hospitals on the basis of the previous year's turnover. For physicians, also the old payment mechanisms were important, and in many countries, GPs simply received the same salaries or the same capitation, or they received a payment based on the previous year's turnover, which was not changed as a result of the COVID-19 and the drop in activity. And an alternative was also created in several countries by existed in many countries to allow physicians to continue to provide services, because they could provide e-health services, and these were already available payments for e-health services in many countries, but sometimes the restrictions were relaxed to be able to more easily provide more e-health services. Nevertheless, some countries introduced new payment mechanisms to compensate income loss. For example, in Belgium, a quick cash advance based on past expenditures was given to hospitals. Germany was an important example of a country that introduced a new per diem payment for empty beds, where the empty beds were calculated in comparison to previous year's activity. And because this is an interesting example, we have the spotlight on Germany, and Wulf Leber will provide more information on this. In addition, also in some countries we had payments for e-health services that were introduced for hospitals for outpatient care, because many countries hospitals also provide outpatient care, or investments for e-health were covered. Finally, for physicians, there were compensatory payments that were introduced in several countries, either per quarter or giving a monthly allowance, a daily compensation, or a one-time lump sum. And those countries that did not yet have e-health fees created new fees for e-health consultations in order to allow physicians to provide alternative services. Higher payments were not important to compensate income loss for hospitals, but they are important to pay for COVID-19 services in several countries, and they are important in some countries now to provide incentives to providers to resume the normal activity when the lockdown finished, in order to provide the services that were put on hold earlier in the year. And for physicians, sometimes the fee-for-service level was increased to compensate for a drop in activity, so the remaining services were compensated at a higher rate. Also to compensate in countries with a mixed capitation and fee-for-service system for the drop in services provided by providers. And while most of these mechanisms led to changing the payment mix because the basic or the fixed part of the payment system became more important as the activity-based component dropped, England was the only country that made this explicit by saying that they completely suspended the activity-based payment for hospitals and the quality-based payment for GPs. And in addition, several countries introduced some direct transfers from government for certain parts of the costs, and even donations from citizens were important in some countries like Bulgaria, and sometimes fixed costs were covered for both hospitals and physicians. So this brings me to paying for COVID-19, and I would like to hand over to my colleague, Ruth Waitzberg.
Hello, so thank you, Wilm, for the first part of the presentation. And now I'm going to present about strategies that different countries and different public payers implemented to pay for COVID-19 services. And here in this part, it's very important to think about the balance of the incentives, because these new payments for COVID attempt to provide the incentives for payers for providers to provide care based on need. And when we talk about need, we mean the proper amount of services, not more than needed or not less than needed, and also for the right patients. So we want to avoid incentives for negative selection of high-risk patients, and COVID patients are very high risk. They are very complex, they are very costly, and we don't want providers to negatively select those. And we also want the providers to provide the right amount of care, not too much and not too less. And on top of it, there are these extra expenditures due to COVID for all patients, not only for COVID-19 patients. For example, the costs of adapting clinics for physical distancing and the purchase of personal protective equipment and sanitizers. So let's see how countries did that. Wilm, can you pass for the next one? Next slide. Thank you. So many countries adopted higher payments. They just increased the fees of the payments that were existing already. And these higher payments are supposed to cover for the higher costs of COVID patients. So for example, in Germany, there was an add-on per case payment for hospitals where extra costs of COVID in hospitals were taken into account. So the costs of ICU beds and ventilators, things like that. For physicians also, countries gave higher salaries or higher fees for physicians to have incentives to treat this kind of patients, because you can think that they are high risks. Maybe providers are concerned of being infected themselves, or they don't have a lot of motivation to go to home visits. So for example, the Netherlands created these higher fees for home visits and higher payments for them to be willing to treat complex, difficult, and even dangerous cases. Next one, please. Other countries just created new types of payments. So for example, new per diem codes for COVID-19 wards where the costs were better calculated and these codes were better priced in order to match the costs as much as possible. For example, new DRG codes were created in Denmark and Italy in order to take into account the different paths and different complexities of COVID-19 patients compared to other types of patients that are in ICU units. There were also new fees for COVID-19 services like teleconsultations that were new in some countries, and physicians also had to receive some new types of fees for new types of services they were providing. For example, in France, they created a new fee for service for visits to nursing homes. Otherwise, physicians would not be very motivated to go and treat this type of patients. And also because this apparently was a new type of services they had to provide. So the next slide, please. Also, some countries did not have to create or change the payment for providers because the old payment was resilient enough to provide the services and compensate the providers in a proper way, fairly, for the services they give. And this is the case for fixed budgets in hospitals, for example, and salaries for GPs in many countries. GPs receive their salaries as usual. They work more or less as usual. They just do different services, but they treat more or less the same amount of patients, and they receive the same amount of payment. So the strength of fixed payments is that it's resilient in times of crisis. On the other hand, we have to pay attention because sometimes this type of payments may create incentives for under provision of services or sometimes selection. So what is right in normal days that we don't have COVID might not be correct for times of crisis and vice versa. And that's why it's important for us to pay attention to these incentives and the balance in regular times and in crisis times. Wilm, the next one. And there were a lot of countries that changed the payment mix also to cover these extra costs that COVID-19 pose on all the providers to treat all types of patients, not only COVID-19 patients. So, for example, hospitals and physicians received in-kind equipment from governments to cover these costs, or they received a cost-based reimbursement for these additional running costs. Sometimes they received lump sum payments every 3 months, and this helped these providers to receive the correct funds and equipment to comply with the hygienic and physical distancing requirements that are new and needed for all the treatments. Next one, please. So just to discuss and conclude our message, activity-based payments, they pose risk on providers, not only on payers. And if in regular times where we don't have pandemics, we know that activity-based payments pose more risks on the payer because the provider knows that there is enough demand. In times of crisis, when demand has a lot of fluctuation, we have to rethink about this kind of payment. So then we have the fixed budgets that the advantage is that they don't have to compensate income loss because there is no big income losses, but sometimes there are low incentives to restructure activity in line with the pandemic. And if providers are not fairly compensated for the extra costs and for the extra efforts they have to give to treat COVID patients, it's not a good idea because it will reduce their willingness to do so. So we saw that governments and public payers assumed most of the COVID-related financial risks, even during the lockdown and after that, and they stepped in to cover these extra costs. Payment adjustments to pay for COVID-19 incentivized treatment of patients and sometimes aimed to steer service provision. And finally, the payments for COVID, they should balance the incentive for selection, so reduce the incentives for negative selecting the high risk and high cost patients, but also balance the incentives for efficiency, so providers provide the proper amount of care, not too much, but not too few. And if you want to know and read more about our findings, Wilm, the next, please, next slide. You are welcome to read our new publication at the EuroHealth publication of the European Observatory of Healthcare Systems. This EuroHealth publications is in the website. Probably Erica will talk about it. Thank you, and back to Ewout.
Thank you very much, Ruth. And perhaps somebody can put in a link to this special issue of EuroHealth. It's full of interesting articles, and it just came out a few days ago. So maybe Erica or Annalisa can put in a link in there. So now we are moving to the countries, and we'll hear some more information from, and we'll start with Germany. So Mark, can I ask you to come on your screen and tell us your experiences with the hospitals.
Hello to everybody. Thank you very much for the invitation to this very interesting webinar. I was invited today to explain you within 5 minutes only what we did in the last time in Berlin, and concerning also the financing, which were the findings during the crisis. So just to introduce our organization and myself, we are the Berlin Hospital Federation, representing the 16 hospitals of the capital, and we do represent them regardless of the kind of ownership, so the public, the private for-profit, private not-for-profit, altogether 60 hospitals. And additionally, that's a special feature for the Berlin Hospital Association, we also do represent long-term care facilities. And for these organizations, hospitals and long-term care facilities, we, despite being a private not-for-profit organization, we have legal tasks. For example, we do negotiate the prices which hospitals can invoice to the statutory health insurance funds, or we also negotiate the hospital plan, and have our tasks also in quality assurance on the federal states level. Just to provide you with an overview what the 60 hospitals of Berlin did during the crisis, I listed you kind of all the features we had during the time. We established, for example, test centers. We trained personnel as a very important topic to get enough nursing staff for our intensive care units. We developed and established a new system of provision of care for the COVID patients. So we defined this several levels in which the patients, the COVID patients, were given into depending from the severity of their illness. And besides all this, we took care about that there are enough psychosocial services for our hospital staff, as we have seen that the crisis will also be a personal challenge for them. So all this for you as an overview that you can understand that hospitals really prepared a lot to be fit for the crisis. And one of the most important steps to get prepared was a legal step, which was taken by mid of March. This was the lockdown also for hospital care, for elective hospital care. So all the treatments which you can plan for were had to be avoided. This in Berlin led to sinking of the occupancy rate of the hospitals from an average 85% to now during the crisis to 55% also only. And also all the ambulatory care took not place anymore. Patients weren't coming anymore or having respect to COVID patients' needs. So we did not provide any ambulatory outpatient care anymore in the Berlin hospitals. And we had a political signal from our federal government, from our federal minister for health of Germany: no hospital shall suffer economic disadvantage of the crisis. And for this reason, the so-called Hospital Relief Act was given in early March. And this act was comprising some very interesting measures. The most important of them was the keep-free fees. These were at the beginning, by legal decision, 560 euro per day per bed, which was kept free for every hospital, so regardless of the case mix. And so as this was a political and legal decision, was not the stake of the hospitals, that some of them, we now know, had more income with this keep-free fee than usual. But as this was a legal decision, we did not blame for. This 560 euro keep-free fee was then adjusted or diversified in mid of summer in July. And now we had a 5-step keep free fee, starting with 280 euro per day per bed in the psychiatric care, up to 760 euro for the university hospitals or the maximum care providers. And for Berlin, this keep free fee had an amount of finally 366 million euro, which was paid till end of September. Since then, no money is paid anymore, as politics decided that the crisis was ending up already in Germany. As a second very important part of this Hospital Relief Act, we had investments for intensive care bed. This was with a political aim to inaugurate the number of ICU beds. And so we got paid some 50,000 euro per each extra ICU bed. And also this measure ended up in end of September. This provided another 28 million euro for Berlin, so some 550 beds, which have been paid for. The mechanism behind is that hospital providers applied for at the regional government, was the application was approved, and then the money was given and the bed is there. And in Berlin, we also got paid the ventilators by the regional government, which was a good aid for. And another part of this Hospital Relief Act is that the we got paid extra the nurses' costs with an extra amount on top, as we have this year the specialty that the nurses' costs were calculated out of the GDRG system and had to be paid in an extra budget. And in order to take care of the lower provision of cases, we had a raised nurses' fee, nurses' costs paid by this Hospital Relief Act. Other very important measures have been extra costs for extra material, which we needed, for example, to purchase the protection material for our staff. And beside all this money, some extra procedures have been installed. For example, the statutory health insurance funds have been asked by law to pay the hospital bills within 5 days only. Usually there is no restriction. And also the medicinal service of the health insurance funds was limited to a rate of 5% only for investigation of hospital bills. Usually this is about 12.5% of investigation. Also, these two measures were bringing some more liquidity for the hospitals. But finally, we cannot say yet whether the hospitals in general were overpaid or not. We got with a so-called Hospital Future Act the option for hospitals that for those who have the impression to get paid too less, that they can seek for adjustment at the end of the year. And finally, also our staff got another 100 million euro as a bonus paid for with this during the crisis. So a lot of financial aspects to the stake of the hospitals, which is most welcome. Just to end up my presentation, we are still now for sure in discussions about how to manage the second wave, which we are now heading for. In Berlin, right, actually, already 20% of our intensive care beds are filled with COVID patients. So we here are faster than the other federal states and have the real second wave already in town. And this needs for us that we come back to the financial measures of the Hospital Relief Act. And we hear now from the federal minister that with some modifications, there very soon will be a turn back to this help. Just to give you another idea, there was in June the so-called boom booster package of the federal government, bringing some 160 billion euro for the German economic. Some 3 billion of those have been provided for hospitals with a focus on digitalization. This means for Berlin, some 220 million euro will be provided with the next year for the Berlin hospitals in order to help them getting out of the economic crisis, being connected to the COVID crisis. And hospitals, wise institutions, we learned by suffering the crisis that our DRG system needs some modification. So we started a process within the hospital scene to analyze the weaknesses of the GDRG system, and we are actually in discussion about what will be the financing hospitals for the hospital system after the crisis. So thank you very much for your kind attention.
Thank you very much, Mark. This is very interesting. I already see that there are lots of questions coming in about also the future of payment and etc. But let's now we'll quickly move to Wulf, who will talk about the payer perspective in Germany. Wulf, the floor is yours.
I'll tell a bit about the German situation. Up to now, Germany had a mild development of the COVID pandemic. Here you see the upper line. We have got about 30,000 ICU beds, and the bottom line is the number of beds which is used for COVID patients. And up to now, it's always under 10%. You just heard from Mark that we have a new situation in Berlin, but nationwide, there is no problem up to now. And that might be in the success of the advice you see on the right side. We told the people, stay away from hospitals, stay at home, and don't make the hospitals too hot spots. We had a mixture of incentives. First of all, we have no fixed budgets in Germany, so it was no problem to finance the COVID patients by DRGs, but we have additional incentives, vacancy financing, payment for each additional ICU bed, additional fees for testing, payment for personal protective equipment, increase of daily nurse fee, and a bonus of payment for nurses. Mark mentioned some of these. The most important was the vacancy financing, which started in the middle of March. The compensation was equally for all beds in Germany in all hospitals and was 560 euro per day. That was too strong for regional hospitals and it was too low for university hospitals. That was clear from the beginning, but it took 3 months to differentiate the payment. Altogether, we now have paid about 10 billion euros for compensation, a lot of money, just about a plus of 10% for the hospitals in their income. What's next? In these days, we discuss how to cope with the next wave, and we don't know the result, but I have a guess. The guess is there will be a concentration of payments for those hospitals which are important for COVID treatment. So there won't be another general compensation for all hospitals, but a concentration of the payments to the, let's call them, COVID hospitals. A little bit difficult is to say what are the ICU beds. We had, so the statistic, 28,000. Then we funded additional intensive care beds, about 10,000. And after that, we had a look in a daily reporting system of the DV, and there was a gap of 6,000 beds. I think that's a very interesting question for health economists to clear why we have got this huge difference. When you look at the year, you see on the right side that the expenses of the German insurance companies didn't go down, but we had additional financing of empty beds, about 10 billion, and a decrease in the case mix. So in the end, more money for less work. So altogether, a golden year of hospital financing. Most of the hospitals have got growth in their revenues. And in some sectors, it's very strong, for example, in the psychiatric hospitals. I think that won't be the plan for the next year. And I think we have a correction of this at the end of next year when the general election has been in Germany. That's so far for now.
Thank you very much, Wulf. This is very interesting. I think that we will now move directly to Poland, to Marzena Tambor, and who will tell us about the Polish approach, which was notably different from the German one.
Thank you. And thank you for the opportunity to share the experience of Poland. So I will start with the information on financing non-COVID-19 services. So the main strategy in Poland is to maintain usual funding regardless of providers' activity. And in case of general practitioners and healthcare services provided within so-called hospital network, there is no much change because these services are paid based on capitation and lump sum payments, so kind of global budget. And these payments are still paid to the providers. However, for the providers outside the network, for outpatient care or also inpatient hospital care, there are some changes because these providers are paid using DRGs and payments per visit. So now there are actually two options. Either they are paid for provided services or they can request advance payments for contracted services. And this is in the monthly installments. And the assumption is that these services will be provided later during the billing period. And recently, this billing period has been extended by 6 months. So providers have time till June next year to provide these services. Nevertheless, still there is some uncertainty among providers whether they will be able to provide these services and to keep the advance payments. And also for the providers within the hospital networks, there is uncertainty about the future funding, so the global budget for the next year. I should also add that there is add-on payments for all healthcare providers, which is equal to 3% of the bill, to cover the cost of an elevated sanitary regime, so purchasing, for example, personal protection equipment. As for the services, COVID-19 services, there are new payments, and these payments are both for the readiness to provide services and also for provided services. And there is a catalog of COVID-19 services. This catalog has been updated quite frequently. So far, there have been already 29 updates, and the catalog has been extended from 6 services to nearly 50 services. And in this table, you can see the main services from this catalog. As you can see, for the inpatient services, inpatient hospitals services, we have payments for readiness, which is payment per bed or per respirator, and we have payments for hospitalization for each day of hospitalization of patient with COVID-19. We have also payments for the diagnostic services, for the tests, for the readiness to provide tests, or for the readiness to take biological samples, and for the performed tests or taking biological samples. And there are separate payments also for the transportation, both for the readiness and for the transport. More recent changes are the introduction of the flat payments for consultation of infected patient, and this payment is particularly targeted at the primary care physicians who are now more involved in managing COVID-19 patients. And this is to keep people out of the hospitals when it is not necessary that they are hospitalized. Also, recently there are some attempts to differentiate payments for hospitalization based on clinical condition. Again, this is to reduce the length of hospitalization and to keep patients rather in the isolation facilities than in the hospital when it is not necessary. I should also add that all these payments for COVID-19 services are covered from the state budget, so not like the general healthcare services in Poland, which are financed from the social health insurance. And that's the main information. If there are any further questions, I will be happy to answer them. Thank you.
Let me second that. Thank you very much, Marjana. If there are questions for Marjana, but also for the previous speakers, for Wulf or Mark, please send us your questions in the chat box. So now we are moving to France. Marie-Camille will tell us about the French response. Marie-Camille?
Thank you, Ruth, and good afternoon to all of you. Regarding France, I will focus more on ambulatory care, as it is specifically the role of the statutory health insurance to commission ambulatory care, whereas the Ministry of Health is more in charge of hospital sector. So in France, ambulatory care professionals are self-employed and paid upon a fee-for-service basis. And there are both physicians and paramedics that are self-employed and paid upon a fee-for-service basis. So it was essential that they were in a position to continue their activity after lockdown. And so measures that have been taken were a balance of compensation of income loss for healthcare professionals, and a balance with the need to pay also, and of course for new COVID-19 services and needs. So during the lockdown, the first measure to be taken was to loosen restriction on teleconsultations, so only for physicians, but it was really much more restricted before. And these teleconsultations were priced the same as in-person consultation in normal times. Then sick leaves for all healthcare professionals were exceptionally covered by the statutory health insurance. And finally, health insurance provided also compensations based on previous year turnover to cover the fixed operating costs of practices. And then at the end, after the lockdown, there has been new or higher fees introduced to cover COVID-19 services and needs. So there was one for the follow-up of COVID-19 patients, one for the visits to older patients in nursing homes, And then there has been a post-lockdown consultation for chronic patients with chronic diseases as a kind of health check after the lockdown. And more recently, there are special fees for performing antigenic tests. Just a quick word about financial hospital fundings during COVID-19. So the Ministry of Health is more in charge, but basically there were two big lump sum payments that were given to acute care hospitals, and another one a bit smaller for psychiatric and rehabilitation hospitals. So I thank you very much for your attention and look forward to your questions.
Thank you very much, Marie-Camille. I know that Erica has been monitoring the chat box. I tried as well. There were quite a few questions. Erica, can you give us a sense of the kinds of questions that we're getting?
Yes, we've had lots of really great, interesting questions that often sort of interlink. So I'm going to actually link some of them together for you. One of the key issues seems to be people are interested in how we should be paying for at-ready sort of surge capacity, things like field hospitals. And that's a question that comes from Anita Charlesworth and Victoria Kristievich. But also the impact of these changes in financing on things like hospital debts. So the sustainability of the hospitals themselves. And that's from Katarzyna Jakubczuk. And then also, is there any evidence on whether or not this spending has been rational? So I think that's also one of the key issues, and that was raised by Ralucha Pop. So, oh yes, and what is in place to deal with the pent-up demand for after the pandemic? So is there, what do we think that might, how do we think that might impact on the causing problems in the system? And that was a question from Brian Turner. So yes, oh yes, and is there any evidence on different approaches to financing leading to different health outcomes? And that was from Joanna Bianchi. So there you go. Quick summary.
Okay, so can I ask all the presenters to share their or put on their video again so that we're all on screen here? We have not so much time left, but I do propose that we take a little bit more time, maybe 5 minutes more at the end, and try to discuss some of those questions. Maybe I would like to start, because I saw those questions earlier as well, about do we already have some evidence on the impact of the payment method on the COVID patient? So maybe Ruth, Wilm, you can give a very quick sense if there's already anything known about that.
I haven't seen any evidence on the effects of the treatment of COVID-19 patients. And I think the interesting part of these cross-country comparisons, when we look at how different countries pay their hospitals, is not necessarily to know whether there are different effects, but it's more to give an idea of what are options, what are different solutions, different approaches to pay hospitals, and to use and to look at what are the problems that countries have experienced when using a particular approach to paying their hospitals. And some of the financial consequences are clear. So whether they like how much money has been spent for COVID-19 patients, or how much money has been spent on compensating providers for income loss. But I think it's much more difficult to understand the clinical effects of these payments.
Yeah.
Yes, I would like to add that this kind of outcomes, health outcomes, and effects on quality of care are things that are influenced by a variety of factors, not only how providers are paid. Payment for providers are important mechanisms. They are not the only ones. So we have to be very careful when we learn about payment to providers, because although they are powerful mechanisms to change behavior of providers, there are a lot of other co-founders and other elements that determine and influence the outcomes. And this is something that we have to have in mind when we study payments to providers. And as Wilm said, still a bit early to see outcomes. We can definitely start looking at it at some point in the near future.
And I think we will. Maybe the question about how to pay for at-ready capacity, which is not occupied but can be used in the future. Wulf, I think you already talked a little bit about it, but would you like to say a few words about that?
First of all, we haven't got a plan in Germany. Every hospital decides what to do, and that's a problem. I think we haven't got any big problems in the payment system, but in the future, we have to talk about the structure of the German country. Too many beds, too many hospitals, and that will be the effect, and that will be a discussion in the second wave as well. The payment system is too much concentrated on the provision of treatment, and not there's no component for the readiness. And I think there will be a discussion and a change in that point.
Yeah, thank you very much. So maybe then I will move to Mark. And Mark, there was a question about will the health systems, and maybe you can talk from the Berlin perspective, come under increased strain, because of catching up after the pandemic. What is your view on this? And maybe you also want to react to what Wulf just said about the capacity in the German system. Mark?
Yeah, thank you very much. I indeed would like to react to what has been said before, to the question whether there is some impact on the financing of crisis in hospital care. I won't say so. This is short term. This is about liquidity, safeguarding liquidity for hospitals to overcome the crisis. This has nothing to do with the provision of care. But I would say it is indeed depending from the prerequisites we had already before the crisis. And dear Wulf, to just start argue with you, you said there are too many beds, too many hospitals, but I would say it was in fact an advantage for Germany that we had this great number of intensive care unit beds, and have been able to augment this number even during the crisis. So, and if you look also at the occupancy rate, especially for the hospitals in Berlin, 85% of occupancy rate is, I would say, a good sign for that there is not too much beds, at least not in the capital. This might be an adjusted theory for some rural areas, that there might be some hospitals which need some change, but just this as an entry. And for the post-pandemic time, yeah, as I said, we are preparing on the hospital side to present an idea on how hospital financing could be organized after the pandemic crisis. We saw that we need money for the services for public, that hospitals beds are there. This should be paid already. And then we can also get into the discussion which kind of beds should be paid for just being there. This is, let's say, open for debate. But what is now working with the actual GDRG system, that hospitals only get paid when they treat patients, this is not the right approach neither. So this is just the start into the debate post-pandemic hospital financing, which we have now in Germany.
Thank you very much, Mark. It's very interesting. I think that if you are having this debate, can we then also broadcast it, about these different views on the German system with the many beds and the appropriate number, and then we'll invite Reinhard Busse as well, and we'll have a great time. We'll have an hour for that at least, or maybe a day, I don't know. But to your last point, I would like to go to Poland and also to France. Apparently, there is a discussion in Germany how to change hospital financing in the future. Do we have a similar discussion about that in Poland, Marzena? It seemed that you didn't really change that much in your system during the pandemic. Are you expecting any changes going forward?
Yeah, we didn't have to change much because of this hospital network and kind of global budget which we are using. But still, as I said, there are some concerns about the future budget. So because this budget, global budget, are set based on the provision of services as well also. So the hospital are afraid that this budget will be cut for the next year. So and of course we have new mechanisms for payments for COVID-19 services. So if there is no COVID, that we will just go back to the usual financing of healthcare services. And still there are also some concerns about the increasing debt, because I saw one of the questions about this, because the debt of hospital in Poland is a huge problem. So some hospitals are already afraid that this situation can increase the difficult financial situation, although we have some evidence on the surplus generated by some hospitals who are getting resources both for the usual payments, and then for the COVID-19 services.
I think you're pointing to a very important issue in many countries in the eastern part of the European Union, the hospital debt issue, which is of course during this pandemic even graver. The same question to you, Marie-Camille. Is there a discussion now in France to change hospital financing or financing in general? I know you didn't talk about hospital financing per se, but are there discussions that things need to change or will keep changed in the foreseeable future?
Yes, to some point it has already changed since there has been a major kind of reform, and COVID-19 acted as a catalyst to underline the chronic lack of funding that hospitals were experiencing since decades, or at least one decade. And so there has been some increase in pays for all hospital workers at the beginning of the summer, and I think it's not finished. I think there will be they still claim, these hospital workers, for more means, for more money to invest also within hospitals, not just the pay, but also the means to do their work the way they think it should be done. And so COVID-19 was really a catalyst and convinced all politicians and the public and the population that more means were to be given to hospitals.
I think that is something that we probably see in many other countries as well, that it has been a catalyst, especially also for telehealth, telemedicine, and those kinds of services. Unfortunately, I will have to wrap up this meeting. I know that there are still many questions. We saved them and we'll see what we can do with them or get back to some of you about some information that we have. But before we do, I would like to ask Wilm for a few of his takeaways. He gave the keynote together with Ruth. And what did you learn?
Yes, thank you very much for all your contributions to this meeting and for the interesting questions. I think what we have seen is that that all countries have made adjustments to compensate hospitals and physicians for the income loss that they have experienced as a result of the crisis. And most countries have also tried to make some change to the payment system in order to pay for COVID-19 related health services. To compensate for income loss, the easiest approach was to simply continue paying with the old payment system, but this creates problems, as we have seen in Poland, because it may create uncertainties about whether there will be an adjustment afterwards to account for the change in the activity. In other countries, like Germany, the new payment system for empty beds has certainly led to high compensations for certain hospitals, which had to be adjusted after some period in order to more balance the incentives that lower level hospitals receive too much compensation compared to their costs, while higher level hospitals didn't receive enough compensation. Concerning paying for COVID-19 patients, I think there's an interesting balance between providing incentives that make it attractive enough to treat these patients with the aim of steering patients to certain providers. And this is something that Wulf also mentioned, that it will be important to make sure that COVID-19 patients are concentrated in their treatment at fewer hospitals that really have the necessary capacity to provide good quality care to these patients. And I think France was interesting in the many different, and also Poland in a way, in the many different types of fees that were introduced as a result of the crisis, with France having introduced this, for example, this fee to go to a higher fee to physicians to go to nursing homes and to see the most high-risk patients in their environment, and avoiding that they have to come to see them at their office, and also all the fees that were introduced to incentivize e-health provision in many countries. And with the discussion, I think it also became clear in a way that the COVID-19 crisis is in a way a catalyst maybe for future reforms of hospital planning, for thinking about how to deal with hospital beds, how to deal with hospital debts, and whether hospitals should be financed differently in general, financing more the availability of hospitals and reducing maybe the activity component in the payment. And on the other hand, as a catalyst also for e-health provision and payment systems for e-health, and relaxing the requirements for e-health provision. So I think that were my main takeaways.
I think that is a very comprehensive wrap up and takeaways for everybody to contemplate. And we will be working on this issue, and we will probably publish more about this issue going forward, and also in our HSRM monitor. So keep your eyes peeled on our monitor, but also we will have eventually an article on health policy around this issue. Thank you very much, everybody, for joining. Next week, same time, same day, we have another webinar, namely on protecting health workers while maintaining surge capacity. Very interesting, very related subject. So I hope that you all join there as well. And the very final thing I would like to say is, when we close this meeting, afterwards you get a pop-up where you can evaluate our webinar, and it's incredibly helpful for us so that we can target better the kinds of topics that you want to hear about, and to make them as relevant as we can for you. So I hope to see you next week, and until then, stay safe. Goodbye.